I think we can go and get started. Hi, everyone. My name is Alex Taylor, and I'm Chief Cardiology Fellow for Education here at the University of Washington. It is my distinct pleasure to introduce our Grand Round speaker and this year's James H. Caldwell Visiting Lecturer, Dr. Doug Drachman. Dr. Drachman is an interventional cardiologist on the faculty of the Massachusetts General Hospital and an assistant professor of medicine at Harvard Medical School. He completed his medical school training at Duke University School of Medicine, internal medicine residency, cardiovascular disease, and interventional cardiology fellowship training at the Brigham and Women's Hospital, and subsequently completed a fellowship in vascular medicine and peripheral intervention at the Mass General. Dr. Drachman has dedicated his career to cardiovascular medical education. He has served as director of both the cardiovascular disease and interventional cardiology fellowship programs at the MGH. He holds major educational leadership roles in several national cardiovascular societies, including the AHA, SCI, as well as ACC. He is vice chair for the annual scientific sessions at ACC this year and will serve as chair for 2023 and 2024. In addition to his educational leadership roles, he serves as director for catheterization laboratory quality and safety at the MGH and has an active clinical practice in the cardiac cath lab where he performs coronary as well as peripheral vascular interventions. On behalf of all the cardiology fellows, I would like to extend our sincere thanks to Dr. James Caldwell, our former cardiology division head, for making this rich educational opportunity possible for all of us. Dr. Drachman, we are thrilled that you're able to join us virtually this year as our Caldwell visiting lecturer. We are excited to hear your presentation this morning on multivessel coronary artery disease and acute myocardial infarction. What is the best approach? Thank you so much.
Alex, thank you so much for such a kind welcome and introduction. It's really a privilege for me to join you here. I think perhaps many of you recall that this visit, now virtual, is really essentially 2 years in the making. I think I was invited to serve as the Caldwell visiting professor in March of 2020, but the pandemic had other ideas. And we actually converted my intended visit to a virtual presentation then, which was done by Zoom. And I think was actually my first experience with Zoom, my first presentation virtually, essentially ever. And I really think that as we reflect back over the past 2 years, really so much has evolved. We've all changed so much. And I do really feel a distinct privilege and like I'm there with you. So it really is a great honor here. I really like to extend thanks before I speak to Rose Freeman, who had extended this invitation on your fellows group behalf. I know that she's away today, but was just so gracious and thoughtful as always with everything she does. Sally Habecker has just been amazing organizing everything, and her spirit sort of shines through in everything that she does through emails and many of our communications and conversations. And Alex, I'd really especially like to thank you and your co-fellows for really inspiring me, and having a chance to meet you and see you face to face virtually yesterday was really a wonderful experience for me today. And I hope yesterday, and I hope that we'll continue some great conversations today. And finally, I'd particularly like to thank Dr. Caldwell, who's really made this all possible with his tremendous legacy at the University of Washington, and for providing this opportunity for me, for your fellows. And I hope it's an enjoyable experience for all. I want to embark on this particular presentation by a brief forward. I really think that the treatment of multivessel coronary disease in patients who present with acute myocardial infarction is a topic that has incredible real-world application. The evidence base has evolved so rapidly over just the past 7 or 8 years, and our guidelines have really changed to reflect this in a very dynamic way, and it tremendously influences us as interventionalists at the point of care, where sometimes your gut instinct and the evidence base may not totally line up, and you have to make difficult decisions that are often instantaneous for how best to serve your patients. And so I think, many of us feel very passionately about our decisions as we deal with these circumstances as they arise. And I think it's helpful for us all to evaluate this topic, the evidence and the shortcomings, so that we can make best informations for our patients and make best decisions for our patients with the information available. These are my disclosures, which are not germane really to the presentation today. And I hope in about 40 minutes to present to you the context for multivessel coronary artery disease and STEMI, to describe the evolution of our current treatment recommendations and paradigm, to review the recent randomized controlled trials that have really changed our practice, and to pepper this with some clinical vignettes. By way of background, really about 40 or 50% of patients who present with STEMI have significant lesions in non-infarct related arteries. Multivessel coronary disease, when it's present, is associated with higher mortality and rate for reinfarction, whether this is due to the presence of multiple vulnerable plaques, not just the infarct-related artery, but those other vessels that have stenosis, whether that might confer endothelial dysfunction or impaired perfusion at other sites aside from the infarct territory, whether these lesions might undergo microvascular spasm and create ischemia elsewhere, if there's then reduced contractility in the myocardium aside from the infarcted segment. All of these may contribute to pathobiology that confers worse prognosis. In this study by Jim Goldstein and colleagues at the Beaumont Hospital back now over 20 years ago, it was identified that in over 250 patients who had presented with STEMI, almost 40% of them had multivessel coronary disease that was complex. And when such multivessel disease was present, the outcomes were worse. Shown here by the dark bar, there was an increased need for repeated catheterization in those who had multivessel disease compared with those who had a single plaque. There was a higher rate of recurrent acute coronary syndromes, the need for repeat PCI or PCI of non-infarct related segments, or even progressing to the requirement for CABG surgery. What are the treatment strategies we have for dealing with patients who have multivessel disease who present with STEMI? Well, you can consider culprit vessel intervention only. So you only treat the vessel that has the infarction or the occlusion, and you would only consider revascularizing other segments if there was spontaneous ischemia or perhaps high-risk findings of non-invasive assessments. You could do culprit vessel intervention with the staged PCI that's very deliberately planned, maybe deferred during the index hospitalization of those non-culprit lesions. Or their so-called multivessel intervention, which means just treat whatever you see at the index procedure. We've had a lot of conflicting data about what's the best way to go. How do we treat multivessel disease? In the past, we relied on observational studies, meta-analyses, but more recently have the benefit of randomized controlled trials. But in the past, especially, there's a great deal of heterogeneity about who was included in these assessments, what were the protocols, what was the timing of the intervention? Was it done during the index presentation at that index procedure during that hospitalization or subsequently? How do they statistically analyze the outcomes and what were the endpoints? All this was kind of mixture, and it was very difficult to develop consensus. In the previous guideline, initially, I'll refer to the one in 2013, there was a feeling that the non-culprit revascularization or multivessel intervention was associated with harm. There was a risk of procedural complications, maybe longer procedure time, more contrast was used, or maybe patients were at higher risk of stent thrombosis if you tried to treat another vessel at the same time as the index procedure on the infarct-related artery. Maybe a prothrombotic milieu exists inside. All these observational studies and meta-analyses seem to point to worse outcomes when people pursued multivessel intervention. So as a result, the 2013 Stemi Guideline gave a class 3 recommendation, namely harm, for the consideration of PCI of a non-infarct related artery at the time of the primary PCI in patients, unless they had hemodynamic compromise. However, it was noted that there could be a class 1 indication of the treatment of a non-infarct related artery at a time separate from that actual index procedure if the patients had evidence of spontaneous symptoms or demonstration of high-risk myocardial ischemia. And they thought it was also reasonable in a non-infarct related artery if there were non-invasive testing findings that showed evidence for ischemia subsequent to the index intervention. In 2015, however, there was a about-face in this particular recommendation. Namely, instead of a class 3 recommendation, it was upgraded to a class 2B to consider treatment of the non-infarct related artery. And this was really following on the heels of 3 important randomized controlled trials that we'll discuss in turn. And this was allowable now in patients who were hemodynamically stable, and either it was considered at the time of the primary PCI, or it could be considered during the index hospitalization at a time staged following the primary PCI. I'll just point to the conclusion here briefly to say that these guidelines have yet evolved again, published just last month, and we'll talk about a continued upgrade in the consideration of staged PCI after the infarct-related vessel is treated. So how do we get there? How do we come from the data in the past to this updated guideline? Well, first, people reflected a lot on randomized controlled trials and additional observational data. and we'll review this. But first, I'd like to present to you a clinical vignette. This is a patient I treated probably around 2017, so just around the time that the guidelines were evolving. This was a 62-year-old man who presented with an anterior STEMI. And if you can see on your screens here, the right coronary artery also has a significant cleft-like stenosis in the mid-vessel here and provides some collaterals to the LAD, which is the infarct-related artery. You can see a stump occlusion here proximally within the LAD. So the LAD was treated, and you can see here a stent was placed in the proximal segment. We could quibble about whether or not there should be additional treatment downstream, but we wanted to avoid complexity involving that diagonal branch that also had some disease. And we'd reestablished TIMI3 flow. So we felt that this was a victory. If you look carefully, however, there's still some ST segment changes on the one lead electrocardiogram at the bottom of the screen, and the patient wasn't entirely chest pain free. So we hosted a discussion with the team that was going to be admitting this patient and said, what should we do next? So I'll pose to you, and you can think in your minds, what would you do? Should we do no additional PCI? So that's the culprit vessel only strategy. Should we only go after the right coronary artery if there's spontaneous ischemia or a high-risk non-invasive study? That would have been the 2013 guidelines. Should we consider the PCI of the right coronary artery 2 days after the LAD PCI? Maybe more in keeping with the 2015 update, or possibly in the same procedure as the LAD intervention here. So I'll tell you, we thought about this carefully, but because it was a relatively straightforward looking lesion, we simply placed a stent there in the same index procedure and had this outcome that looked angiographically very satisfactory, and this patient did well. But I think we can discuss what's the rationale for making this type of decision. Would you support that in your own practice? And what evidence base can we rely upon? So as you think about the evidence base, there are observational data and meta-analyses that really kind of governed how we thought about multivessel intervention in STEMI in the olden days. And more recently, there were 3 clinical studies, PRAMI, Culprit, and DYNAMI-3 Primalty. That name just rolls right off the tip of the tongue. That was a Danish study looking at multivessel intervention. And these were all performed before 2015, when the new guideline update was published and served as the backbone for the revision of their recommendation for non-culprit revascularization. And more recently than those studies, there now is Compare Acute, Complete, Flower MI that was just presented at ACC 21, and Culprit Shock. And we'll discuss each of these in turn so we can see how this has continued to evolve our perspective on the treatment of patients with STEMI and multivessel disease. In the olden days, we really relied on contemporary observational data to determine how we should treat these patients. In a Canadian registry, this retrospective registry, there were 6,500 individuals who were considered who presented with STEMI, but also had multivessel disease. About a fifth of those underwent multivessel PCI during the index procedure. So that's the MVI strategy I talked about at first. About half as many had a stage PCI during that index hospitalization. And really close to 3/4 of the individuals in the registry had only PCI of the infarct-related artery. And there was 2-year follow-up that mostly focused on all-cause mortality and also repeat revascularization. What they found off the bat was those individuals who underwent the multivessel intervention in the index procedure had the worst outcome in terms of mortality. Those who underwent only intervention on the culprit vessel and no other staged intervention had second worst mortality, and those who had a staged intervention had the lowest mortality. And there are all sorts of confounders here. You can imagine if you survive long enough to have a staged intervention, that you've made it over the hump. And so there's all sorts of survivor bias and other things that come into this that we'll talk about further. But I just want to kind of place this concept in your mind here. Additionally, when we think about repeat revascularization, the individuals who underwent multivessel intervention had at first what looked to be the highest need for repeat revascularization, but that was subsequently overcome at about 6 months out by those who had the culprit vessel only. So those who had known residual bystander lesions underwent a greater rate of repeat revascularization after a couple of months from time of discharge. And the ones who fared best, not surprisingly, were the ones who had the staged intervention to take care and ideally completely revascularize the lesions at the time of the index hospitalization. So their conclusions were that the culprit vessel staged interventional group had the lowest mortality in repeat revascularization. and that those who had the culprit vessel only had the highest rate of repeat revascularization. But questions were raised like, why is there a lag time before they needed a repeat revascularization? Was it in the context of they're coming in for follow-up, having non-invasive assessments, having other conversations that record that they were having ongoing symptoms and then being brought back? Or are there other potential confounders? Or is there something about the biology of these lesions that requires attention and the warranty runs out, if you will, within 4 to 6 months or so after the deferral of intervention at the time of index presentation? In conclusion, they also identified that multivessel intervention was favored for those patients who had required intra-aortic balloon pump, so probably a sicker cohort of patients, those presenting with an LAD infarct, or LAD disease in the non-infarct related artery. They're more inclined to be treated with subsequent PCI, and maybe for rescue in those who are sicker. Whereas the culprit vessel only was favored in those who presented with renal dysfunction, liver or GI disease. Non-infarct related artery was not the LAD. So you can think about, this is retrospective data, what influences the clinician at the point of care to make these types of decisions. I think that's the value that we get from these retrospective cohorts. In a more contemporary meta-analysis, this is all looking at observational studies in retrospect. They did this Bayesian analysis here to establish effectively whether culprit vessel was better than multivessel treatment in the index procedure. And it looks like there's a trend towards improvement of culprit vessel only. When looking at the culprit vessel only versus multivessel treatment in the index procedure, you see that there's a little bit of an inflection point where most of these trials fall on the side of culprit vessel only being better until sometime perhaps after 2013, where you see a trend towards improved outcomes with multivessel considerations. And this is in the context of evolving guidelines that steer people to know whether you should empirically try to treat at the time of the index procedure or not. In addition, here, the culprit vessel only versus staged, we can see that staged intervention fared better than culprit vessel only. So this idea perhaps of mortality being improved, as we saw a signal as well in the Canadian registry, these patients seem to fare better when they have a staged intervention than when only the culprit vessel is treated. And certainly staging seems to provide a better outcome than the multivessel in the index procedure, as we also saw in the Canadian registry. But again, this could be confounded by survivor bias. So when we think about these registry and retrospective cohort studies, there certainly are some fundamental limitations. Certainly there can be confounding variables. What really drives or motivates the interventional decision at the point of care? There's probably a lot of selection bias that happens at the time of the index intervention, and really the sickest patients might have been inclined to get multivessel intervention. That was certainly consistent with the guidelines in 2013 that advocated for the consideration of multivessel intervention in the context of shock or other complex STEMI presentation. Survivor bias, if you survive your primary PCI to get a staged intervention, that really can confound some of the data as we look at this retrospectively. Also, there are unknown variables about the complexity of the bystander disease. The case I showed, the right coronary artery was a pretty straightforward one. That's why we chose to treat it there. But in certain other circumstances, you just can't judge when you look at a registry or a retrospective observational data how complex the other lesions are. And maybe some people choose or don't choose to treat them because of those factors. I think ultimately we should look at these findings as hypothesis generating, but we really need prospective studies. So fortunately, we have them. The Primalty study was the really first contemporary randomized controlled trial looking at how to deal with non-culprit lesions in the context of acute STEMI. So in this study, first, when patients presented with acute STEMI and then underwent successful infarct-related artery PCI, so at the time of their successful, first half of the procedures done, they were then evaluated to see if they had multivessel disease, namely a stenosis of greater than 50% in a non-infarct related artery that seemed to be suitable for PCI. So probably greater than 2 millimeters. It couldn't in diameter, it couldn't be a left main stem lesion, not cardiogenic shock. They excluded people who'd had CABG before, and it wasn't going to be treated if it was a chronic total occlusion. And then they randomized these folks. They were aiming for 600, and the goal is to randomize 300 in each arm to undergo preventive PCI. So if you saw a lesion more than 50%, put a stent in it. And or the other group was going to be no preventive PCI. So regardless of what you see, you leave it alone. And then you follow up the patients at 6 weeks and then annually thereafter. And what they found was that the primary endpoint, which was cardiovascular death MI refractory angina, this composite endpoint, was dramatically lower in the group who underwent prevented PCI. Only 21 had it. So that was like 9% of the patients who underwent this preventive PCI. Only 9% of them had this composite endpoint within the time duration of the trial, whereas 53 in the no preventive treatment had it, so 23%. You can see here by these Kaplan-Meier curves, a pretty stark difference in the result of patients who did not meet this primary outcome. The relative risk reduction was 65%, and the absolute risk reduction was 14%. So a pretty robust benefit to the treatment of these, so historically felt to be bystander lesions after the successful treatment of the infarct-related artery. When we look at, what fueled this in terms of each of the composite elements of this composite endpoint, we see that there was a reduction in death, there was a reduction in non-fatal MI, and there was also a reduction in refractory angina in these individuals. So each of these components was actually reduced by the empiric treatment of a greater than 50% lesion. Some of the limitations of the study: first, the trial was halted early by the DSMB because they identified benefit and it was felt no longer to offer equipoise. There also inclusion of all lesions greater than 50%. I mean, typically in the cath lab, we think about lesions greater than 70% as likely by angiographic phenomena being flow limiting. So it raises the question of, what's really the cutoff? How often should a PCI be performed in these extra lesions? And then also in PRAMI, the non-infarct related artery PCI was only performed at the time of the primary PCI. There wasn't really the opportunity for staged interventions. And finally, the randomization occurred following successful infarct-related artery PCI. So there was, only the sort of as treated group. There wasn't this sort of intention to treat confusion in these groups, but also they had to survive and successfully undergo the infarct-related artery in this particular cohort. So a follow-on question that people asked following PRAMI was, is the benefit of this preventive PCI also present if the non-infarct-related artery PCI could be staged? And so a couple of years later, the culprit trial was designed and then completed. And basically in culprit, they randomized almost 300 STEMI patients to a non-infarct related artery PCI during the index hospitalization. So not during the index procedure, but during that index hospitalization. And these patients were also stratified in the two groups, namely if they got the non-infarct related artery treated or if they didn't get it treated, they were stratified to make sure that there was an adequate and equal number of those who presented with an initial infarct in the anterior distribution, and whether the duration of the infarct was less than or greater than 3 hours, just to make sure that we're dealing with, equal subgroups in these two arms of the trial. And the endpoint was all-cause death, myocardial infarction, heart failure, or ischemia-driven PCI at 12 months. And basically what they found was that composite MACE rate was considerably lower in the group that underwent the complete revascularization. It was 10% in those who underwent the complete revascularization, whereas it was double that in those who underwent infarct-related artery treatment only. And so the hazard ratio was actually 0.45 in this group. And you can see that the main issue, there's a trend towards the reduction of all of the composite elements here, recurrent MI, heart failure, and repeat revascularization, but none of them had individually met statistical significance, but in the composite endpoint, they certainly did. And then also what's interesting is, there was a staged intervention done, but there seemed to be no safety cost included if you did a second stage procedure. So there wasn't like an increased risk of stroke. You didn't like double your stroke risk by doing 2 cases instead of 1. There wasn't double the risk of bleeding, and there wasn't double the risk of contrast-induced nephropathy. If anything, these numbers look the same or slightly lower in the group who underwent this staged procedure, but not statistically different in any case. So in looking at the Kaplan-Meier curves with respect to the major adverse cardiovascular events of those who underwent infarct-related artery-only treatment versus those who had complete revascularization, you can see that this is dramatically reduced. And I will just simply superimpose, they did follow-up at 5 years, and this was a very durable outcome out even to 5 years after that index treatment strategy. So if you underwent complete revascularization, considerably better outcomes in terms of major adverse cardiovascular events extended out to 5 years compared with those who underwent culprit vessel only treatment in that index hospitalization. And it was a robust finding, including even outcomes such as death or MI. So maybe there is something to the pacification, if you will, or stabilization of other non-infarct related lesions that affords a benefit that even includes a mortality benefit that is extended and durable even out to 5 years. So how do we put it in context? Why were the culprit findings different from prior studies or these retrospective analyses? I think ultimately observational studies are non-randomized, they're retrospective, and or they included subgroups of primary PCI studies. So these were always sort of selected patients, or the criteria that were used to evaluate the outcomes were hard to kind of homogenize or compare to more contemporary randomized controlled data. And also, I think inherently there's a selection bias of the patients who undergo or underwent prior to the updated guidelines multivessel PCI. They tended to be sicker patients where the feeling or the need to treat these extra lesions was often fueled by a concern about something going on clinically with the patient. In addition, though, time passes and there's been improvements in our technique, in the technology that we use to perform PCI. There's the ability to do additional PCI without as much penalty, whether this is afforded by the fact that in acute coronary syndromes, we use a lot of transradial rather than transfemoral access, so bleeding is lower. Actually, mortality has been shown to be lower with transradial access in acute coronary syndromes. Our pharmacology is sort of more finessed. The P2Y12 inhibitors we use are more potent. We seldom use 2B3A inhibitors that led to more bleeding. There's other infusible platelet blockers that can be helpful at the time to reduce adverse events. And the stent design has gotten much more finessed as well, that affords better long-term outcomes with lower risks of stent thrombosis, better stent delivery, better ability to tackle complex lesions that might happen more often when you're doing a staged PCI than when you're just doing an index lesion in a patient who comes in with a STEMI. So a lot has changed kind of in the backdrop. When we think about, why culprits show these benefits, is there something else, some other mechanism about why treating a non-infarct related artery can improve outcomes? Is it really a bystander lesion? Is this truly a biologically passive stenosis? These are not the lesions that were studied in COURAGE or ischemia. These are not chronic stable angina lesions. There might be something different to the actual makeup of a non-infarct related stenosis in a patient who comes in with an acute coronary syndrome. Maybe there's pan-coronary inflammation. Maybe there are multiple vulnerable lesions. And while there's certainly thrombosis within the infarct related artery that's visible, maybe these other ones are also highly inflamed and have a higher incidence of provoking acute coronary syndrome after the MI than does a patient who presents with chronic stable angina. And so it calls to question, whether there's a role for plaque pacification with prospective or preventive PCI. And also there could be an argument made that the non-infarct related artery treatment may also alleviate other factors like myocardial stunning. Maybe stunning contributes to the presentations with congestive heart failure after the infarct related artery has gone down and its associated distal myocardial distribution. Maybe a PCI could ostensibly help the LV to function and improve clinical outcomes, or maybe it helps to reduce sympathetic ischemia and other territories that are kind of dragged into the mix when the infarct-related segment is laboring because of ischemia and infarction in that segment. So these are posited contributing factors that we have yet really fully to identify or explore, but it's interesting to think about. So some of the unresolved questions that remain are, which non-infarct-related lesion should be treated? Should it be based on angiographic severity? Should we think about how much is downstream from it? That right coronary artery in my patient that I showed supplied a huge territory, and we thought that should be neutralized at the time of the index procedure. Is it the feasibility of treating it safely? Is it a quote unquote chip shot to put in a stent in that area? Because you never can tell once you've gotten into it. Or is it someone's gut instinct about the vulnerability of that lesion that's left untreated? Or is there something else? Could we use flow limiting physiology? Could we use an intracoronary measure of the flow characteristics within the vessel? So enter now the DYNAMI 3 Primalty trial. That's a study that was designed to try to answer the question about whether FFR could be helpful to guide PCI in patients who present with STEMI with multivessel CAD. So in over 600 patients, after they underwent successful infarct-related artery PCI, they underwent FFR-guided assessments of the non-infarct-related stenoses. So any lesion that was greater than 50% by angiography underwent FFR. And then if the FFR was less than or equal to 0.80, or if the lesion was just more than 90%, they gave it a pass and it would be treated anyway. But if the FFR was less than 0.80 and all those other lesions, PCI was performed during the index hospitalization. So kind of within 2 days of the primary PCI, but they did the FFR at the time of the index presentation. And what they found in this study was that in terms of the composite endpoint, there was a dramatic reduction of all-cause mortality, recurrent MI, or ischemia-driven PCI in the non-infarct related segments over time when you use this FFR-guided treatment approach during the index hospitalization. The median follow-up was about 27 months. And so what they found was the composite endpoint was about 22% in the culprit vessel only treated segment group, and the complete revascularization group, that composite endpoint was 13%. If you kind of drill down on, what are the elements of the primary endpoint and how do they contribute to the composite endpoint, this was really driven by ischemia-driven revascularization. There really, in this trial, was not a difference in the hard endpoints like mortality or non-fatal reinfarction. So, using FFR to determine if there's a flow-limiting stenosis could be effective to identify the ones that needed to be treated and to treat them. Some of the limitations, in this study are, the FFR may be inaccurate after MI. Maybe there are issues with macrovascular tone. Maybe there's a lesion that you assess, and it happens to be undergoing coronary spasm at the time of presentation. I think we've all seen this. The vessels kind of look smaller. You bring them back 3 days later, the vessels don't have as much spasm. That could be the case. There also could be microvascular flow obstructions downstream, edema in the distal microvascular bed. So your FFR, instead of showing flow limitation, may actually factitiously be too high and may not really demonstrate flow limitation there. So some patients may have deferral of an intervention when perhaps they really should have it. And FFR ultimately identifies flow. It doesn't necessarily demonstrate vulnerable biology. This is a little bit of a controversial comment because I think we're learning more about FFR and what role it can play. And I think this is one of the unanswered questions that we'll come to at the end of this presentation. Finally, though, this is an open label study. The operators and the patients knew that there was residual disease that was left over that wasn't treated. And also the trial lacked power to determine death or MI. So some questions are like, if there's a 70% lesion that's left behind, not treated, and a patient continues to have symptoms, that might drive a patient representing. Whether or not this is truly from ischemia remains to be determined. And it's always difficult in these studies to know what sort of precipitates a subsequent target vessel revascularization. So those are the 3 trials that really led to the updating of the 2013 guideline to the focused update to Class 2B in the saying it was okay to treat the non-infarct related artery, even in patients who are hemodynamically stable. And they raised it from a Class 3 to Class 2B and had given the sort of green light for either at the time of primary PCI, like in PRAMI, or planned staged PCI, like was the case in culprit or dynamic Primalty. Okay, so those are the data that led to that update. So since then, though, we've really continued to learn a lot. There have been a lot more studies. There's been a lot more focus on this particular topic. And some of the questions that we've tried to learn more about is, how does FFR help guide the decision-making in acute MI? Is it valid? Does it really show us what we need to know? Does it tell us it's safe to defer? And can flow or physiology really predict the vulnerability? I think that's what we're trying to get at with these lesions. Are they vulnerable? Is something bad going to happen to them if we don't treat them with a stent? And what is the best timing for the non-infarct related artery PCI? Should it be done at the time of primary PCI of the infarct related artery? Should it be done during that index hospitalization? You might need to keep the patient extra 3 days. If the first case is done on a Friday and you want to stage it, do it on a Monday. Is it worth it? Is that better for the patient, or could it be deferred? Can they go home and come back in to have a treatment done? And finally, is STEMI with cardiogenic shock a totally different situation? Is that unique? And should we think about different guidelines or different recommendations than what we've been talking about? These patients who have STEMI but are hemodynamically stable. So in the Compare Acute trial, this is one of the studies that looked more at the FFR guidance for complete revascularization. In this study, almost 900 patients who presented with STEMI and underwent successful infarct-related artery treatment were then randomized 1-to-2, whether or not they underwent FFR-guided treatment of the non-infarct-related artery. So they did the FFR, saw if it was less than or equal to 0.80, and then treated it accordingly. Or twofold as many people underwent blinded FFR of these residual lesions. So the operator and the patient did not know what that FFR showed, and they did not undergo PCI of those other lesions. The primary endpoint in the study was the 1-year cumulative major adverse cardiovascular and cerebrovascular events. And the FFR was performed in all lesions, irrespective of which arm the patient was enrolled in, that were greater than 50% angiographic severity. And again, the cardiologist and the patient were not informed of the FFR if they were in that blinded, non-treated, non-complete revascularization arm. And the intervention could be staged for sometime within the next 3 days after the index PCI. So in the patients who underwent complete revascularization, there were 54% of them who had an FFR that was less than or equal to 0.80. Those were individuals, all of whom underwent then the PCI of those lesions. They did not undergo PCI if the FFR was greater than 0.80. And the vast majority of them had them treated at the index procedure, although about an eighth of them had a delay, a sixth to an eighth of them had delayed same hospitalization PCI. Interestingly, those in the infarct-related artery only group, about half of them also had an FFR that was less than 0.80. And again, these patients were blinded, that finding, as were the operators. And also of interest, only 0.2% of patients had a pressure wire associated complication. So in the time of acute MI presentation, it was safe to perform this FFR evaluation as well, with very little downside. And the outcomes that we saw in this were effectively a composite reduction of major adverse cardiovascular and cerebrovascular events from 20% down to about 8%, and that was statistically significant. And in large part, once again, this was driven by reduction of subsequent need for revascularization. And so here in the outcomes of the Compare Acute trial, shown here again in the Kaplan-Meier format, in Stemi, the FFR-guided PCI of the non-infarct-related artery reduced the rate of MACE if they underwent complete revascularization compared with culprit vessel-only intervention. And this was mainly due to a reduction of repeat revascularization. Interestingly, about half of the non-infarct-related arteries were greater than 50% stenosis were FFR negative. And it was by the authors a description safe to defer FFR in the context of a negative PCI. So I think interesting findings, and there are additional data from subsequent studies that might call to question some of these assertions as well. A sub-study was done on Compare Acute that was interesting, that looked at those individuals who underwent complete revascularization, who had an FFR positive lesion that was treated on the top here. And this is looking at target vessel revascularization or target vessel myocardial infarction. So if you underwent FFR-guided PCI and had a PCI of that non-infarct-related artery, that composite endpoint is up here. Whereas those who were in the non-treated segment, so they did not undergo complete revascularization, if the FFR was greater than or equal to 0.88, so it didn't meet criteria for treatment, you can see that there was some gradient, that the worse the FFR, there's some gradient in terms of the composite outcome here. Here in the blue line is those who had an FFR of less than 0.80 that was untreated. So if you had a slightly abnormal FFR, a slightly more abnormal FFR, and then a criterion abnormal FFR here, you can see that it portended a risk over time of the need for revascularization or maybe even myocardial infarction. So sort of a hint that maybe deferral with a threshold of 0.80 or below at the time of acute MI may be more complicated than we were giving credence to. Certainly, undergoing some more comprehensive revascularization did confer benefit to those who had an FFR that was positive and got the treatment. But to those who had a negative FFR and were deferred, there's a question that remains, could they do better off even with preventive PCI? So the Flower MI study, this is just presented last year at ACC, is another study that kind of looks at this question and gives a little bit more light on that comment that I just made. In Flower MI, over 1,000 patients with STEMI who presented with multivessel disease, so another lesion other than the infarct-related vessel that was greater than 50%, they were randomized 1-to-1 after successful PCI of whether or not they underwent revascularization based on FFR of a non-infarct-related artery, or whether just based on an angio-guided interpretation. So how stenotic did it look? And the mean time delay between the infarct-related treatment and the stage PCI was between 2 and 3 days. And the primary endpoint was 1-year death, MI, or urgent hospitalization for revascularization. So basically, In patients who had an angiography-guided PCI, so if you saw stenosis greater than 50%, they would undergo PCI, had a lower of the composite endpoint here, 4.2% composite endpoint of the death, MI, or urgent hospitalization in those who had the FFR-guided PCI. So if the FFR was greater than 0.80, they did not undergo PCI. They had a slightly higher number of this FFR-guided PCI. So this did not meet statistical significance for a difference, but there was a trend, and certainly the FFR guidance did not confer an additional benefit compared with angiography guided decision-making about whether or not to treat a non-culprit lesion. So if you have a greater than 50% stenosis, you could either do it by eyeball to say, well, the stenosis is greater than 50%, put in a stent, or if you used FFR, it didn't seem to confer an additional benefit. And that's what this study showed. When you kind of look at each of the kind of breakdown in the composite endpoint, maybe non-fatal MI was a little tiny bit higher in the FFR group than it was in angiography, not statistically different. And unplanned hospitalization or the need for treatment of the target lesion at some subsequent point in time seemed to be higher. This is not statistically significant, but it seems to be higher in the FFR guided group. So maybe there's a penalty to deferring someone if they have an FFR that's a 0.8 or greater, and there is an angiographically at least moderately severe stenosis. Some of the methodologic details that may have kind of crept in that influence how this study kind of bore out is that about a third of the patients who presented with STEMI had anterior STEMI. And so there's a question, does FFR work as well? If you have a big territory that's ischemic or reperfused or has edema, can that really tell us what we need to know? Is there a greater proportion of FFR lesions that were in the FFR treated group? There's a greater proportion of lesions that were angiographically indeterminate in that group, whereas those in the angiography treated group, more of them had a 70 to 90% stenosis. Fewer of the FFR lesions were ultimately treated. About 55% of them were treated, whereas all of them, obviously, in the angiography guided group were treated. And the completeness of revascularization was not independently adjudicated in this clinical study, lending some question to what did they really undergo complete revasc? Also of interest, there was a subgroup analysis of the FFR assessed patients in this group. And basically what they saw was those who underwent the FFR assessment who had PCI versus those who didn't have PCI, there was better MACE-free survival if they had the PCI than if they didn't. So again, this goes to show that if you use this cutoff of 0.80 and you don't treat them with PCI, it calls to question whether or not that actually confers, if it really is safe to defer based on a cutoff of 0.80. Because the deferral of the PCI resulted in a higher MACE rate. It was driven largely by the urgent and non-urgent revascularization. But again, here, you couldn't include that these might be unjustified revascularizations. This is an open label treatment. Patients and cardiologists know that there were lesions that underwent FFR but did not undergo PCI. And so if a patient represents with symptoms, they may be more inclined to undergo revascularization. In this study, there were broad confidence intervals in the outcome that really didn't permit definitive conclusion. The event rates were much lower than were expected as they kind of planned the power of the study. And in their repeat calculations, the study would need to be about 8,000 patients large to determine if there really would be a difference between these treatment arms, and that's just not feasible. Only 4% of the patients enrolled had their PCI at the index procedure. So, the question is, can you do the FFR as effectively during that index procedure, or should it be staged to a couple of days after? Is the FFR subject to error in the context of acute MI, especially if it's an anterior MI? And is the vulnerability of that residual CAD best assessed by physiology, or should there be some other parameter? Maybe it's intravascular imaging or something else that we need to consider to determine the vulnerability. And finally, what is the impact of this being an open label study with the operator and patient being motivated to know that there's untreated residual disease? Another study that tells us, how do you time the treatment of a non-infarct related artery is the COMPLETE trial. In this study, 4,000 patients with STEMI and multivessel disease were randomized to undergo non-culprit PCI versus culprit-only PCI. And in that sort of comparison, non-culprit versus culprit-only, in that study, the clinician could also choose if that non-culprit treatment was done in the same admission or if it was done following discharge. And the primary endpoint was cardiovascular death or myocardial infarction. So it's a little confusing to think about what did the study really tell us? Because basically what it's looking at is saying, okay, if you treat only the culprit vessel versus if you treat and revascularize completely during the index hospitalization, it improves the cumulative incidence of death or MI, or death, MI, or urgent revascularization. So this bears up over years after the discharge from the hospitalization. Also, if the operator decides it's reasonable to defer it for the patient to come back after the hospitalization to have it done, the same holds true. If you have revascularized completely, you improve the outcome compared with if you don't revascularize completely. And in large part, a lot of this can be due to death and MI, but it also is due to death, MI, and ischemia-driven revascularization. So it didn't actually compare, like, is it safe if you do the procedure during the index hospitalization or if you defer it? It's rather comparing in those two circumstances that the clinicians decided, how and when they would do it. It did show improvements if you completely revascularize the patient. It's interesting in the deferred group, they deferred it to a median of 23 days. But again, I think I don't know that we can generalize this to every patient and tell every patient it's safe for them to go home and come back. I think you have to use the discretion equivalent to what the clinicians who enrolled patients in complete trial had done. The final point that I want to talk on is the question of, is cardiogenic shock a unique situation? So, the 2013 guideline supported multivessel intervention in shock. That was the one case where they said for a hemodynamically unstable patient, not only treat the infarct-related artery, but it's probably preferable to treat a non-infarct-related artery. It's certainly not, you're not impugned for considering that. So the culprit shock trial that was published just about 5 years ago really kind of changed our perspective on this really dramatically. So they enrolled 700 patients who present with acute MI and multivessel disease defined by a greater than 70% stenosis in the non-infarct-related artery. And these patients all had to present in shock. And they were randomized 1-to-1 to undergo culprit vessel only treatment or a multivessel intervention for complete revascularization during that index procedure. And the primary endpoint at 30 days was just death or renal replacement therapy. So it didn't include, non-culprit revascularization. So when you consider just those hard endpoints and you look at those who underwent the multivessel PCI versus those who underwent the culprit lesion only PCI, there was a lower accrual of the adverse events in those who had culprit lesion only than in those who underwent multivessel. So there seemed to be some signal of potential harm of going after non-infarct related vessels in the context of acute MI with STEMI. In these patients, however, as you look at the details, 25% of them who were enrolled had chronic total occlusions. And so there had to be a good faith effort at CTO PCI during the index procedure in the multivessel intervention group. So in that group, obviously that's going to require more effort, longer time, more contrast and other issues. And with a hard endpoint of renal replacement therapy, that could certainly influence it when you're dealing with CTOs. Those who are randomized to the culprit vessel only, actually about 12.5% of them did also have immediate non-infarct related artery PCI. So maybe there was plaque shift when they were treating one vessel and they had to go and treat another, or something showed up, or the instability of the patient motivated the clinician to treat a non-infarct related artery during that same sitting. But this was an intention to treat analysis. So they weren't considered in that group. And then also another 17.4% of them had a stage PCI, the non-infarct related artery, during the index hospitalization. So it was encouraged. It was not penalized and was not part of the composite endpoint. So in some of our other studies, when you look at that as a penalty, that's what kind of fueled the difference between these groups. And in this one, it was not considered as part of the endpoint. So when we look at the 1-year outcomes too, so that was a 30-day outcome that was presented in that last in the culprit shock presentation. Here is the culprit shock 1-year outcomes. What we see is the curves remain effectively parallel out to 1 year out. So there's not like some accruing penalty to treating only culprit lesion only in terms of mortality. So, that seems to be a stable and durable assessment when they did a landmark analysis. So after 30 days, they set the score back to 0 in terms of death from any cause. And then you see here multivessel PCI as the orange on below and the blue on the top. And these are essentially indistinguishable. What they did find that's interesting is there was a higher rate of repeat revascularization in those who underwent culprit vessel only. 32% of them had it versus 9% in the multivessel intervention group. But also the rate of rehospitalization for heart failure was slightly higher in that group as well. So, maybe there is some non-death associated penalty of not treating as many vessels as possible during the index procedure, but it sort of seems to be more of a penalty in terms of mortality that's associated with that strategy, at least when a quarter of the patients also have chronic total occlusions. So, what are the risks of considering a strategy of multi-vessel intervention at primary PCI in all comers? Maybe there's the sort of exaggeration of the non-infarct related artery stenosis severity, so treating lesions that don't need to be treated. Maybe the stents can be undersized so that as the vessel enlarges, the stent could be more prone to malapposition and thrombosis. Maybe there's contrast-induced nephropathy that is engendered by this approach, or maybe there's a thrombosis risk that is an untoward byproduct of treating multiple vessels at that time. Either it's thrombosis or some inflammatory milieu, or maybe when you treat a non-infarct related lesion, you cause hypotension in a patient, and that causes both stents to go down. Or maybe it jeopardizes other viable myocardium. Maybe when you treat, in my case, that right coronary artery on that patient who came in with the LAD infarct, maybe there's microembolization and a risk of causing no reflow down in that distal right. Maybe you occlude a side branch and cause trouble, jailing a branch and creating all sorts of problems. Or maybe it ultimately reduces the coronary reserve for that patient. So, maybe these are reasons why we should pause before we think about doing multivessel intervention at the time of primary PCI. And specifically, patients who should not get a non-infarct related artery PCI are those who have lesion subsets that are high risk for additional LV dysfunction. So maybe those who present with a calcified vessel where you'd have to consider using atherectomy at that time, chronic stable lesion more likely, those who have stable saphenous vein graft disease where there's a risk of causing microembolization, or lesions where the procedure may be prolonged, whether it's due to vessel complexity or a chronic total occlusion, or if the lesion supplies a really insignificant myocardial territory, or maybe it's a patient-related factor like they have renal dysfunction, or certainly we've learned from these recent studies, shock, those should not have a non-infarct related artery PCI. So I'd like to conclude by sort of touching briefly on the recent update to the guideline. This was just published within the last 2 months. And basically, the revascularization guideline now gives a class 1 recommendation for in selected hemodynamically stable patients who present with STEMI and multivessel disease. After you successfully treated the infarct-related artery, it's okay to stage a PCI of the significant non-infarct-related artery stenosis. So that's a class 1, staging it. A class 2B in hemodynamically stable patients is to consider doing it at the time of the index procedure. CABG for complete revascularization is also given a 2A recommendation. So that's a staged after you've dealt with the infarct-related artery. But still now the turning of the tables, class 3 harm for patients with STEMI who have that is complicated by cardiogenic shock, you should not treat the non-infarct-related artery according to the new updated revascularization guideline. So I just want to briefly touch on the idea that this is a rapidly evolving area of content. There are many studies that are coming down the pipeline looking at how to select the patients, how to select the lesions that we think ought to be treated in the context of STEMI. So in conclusion, we've discussed that multivessel coronary disease elevates the mortality risk that's associated with STEMI. Maybe this is due to the pathobiology in those other non-infarct related lesions. There certainly has been a lot of evolution in the perspective on non-infarct related artery PCI. Previously, it was felt to cause harm. Currently, it's 2B during the index procedure, or even a 1 now in a staged fashion. There are ongoing studies that are assessing outcomes in which lesions should be treated. Is there going to be a role for other physiology? Should we be considering things like IFR or DFR as opposed to FFR? Would that be more effective in a patient who presents with ACS? Should some type of intravascular imaging be used to help identify which are vulnerable plaques? I think that's the holy grail. Which patients, what clinical scenarios should drive us to consider when we treat non-infarct related lesions, and at what time? Should it be 2 days later? Can it be 27 days later? Which of these in head-to-head fashion would bear true or better for our patients? And finally, we might consider even the cost. And is there a financial benefit for patient, hospital, and insurers to prevent readmissions, depending on our decisions and our preventive treatment or our prophylactic treatment of non-infarct related lesions? Thank you so much for your attention. I'd be happy to entertain any questions at this point.
Thanks so much, Dr. Drachman. That was a really a sort of a fantastic overview of a very common clinical problem that we face in cardiology. To the audience members, please type your questions for Dr. Drachman either in the Q&A or in the chat box. While we're waiting for questions to come in, I just had a quick question for you, Dr. Drachman. As you showed on your last slide, it seems that kind of a key unanswered question is in staged PCIs. What is sort of the optimal amount of time to kind of wait between the primary intervention and the stage intervention? In flower MI, the mean delay was 2 to 3 days, and in the other trials, it sounds like we haven't really kind of settled on what the optimal time is. So what factors do you use to sort of figure out that timing for patients?
Yeah, thanks for asking the question. I think that what we mostly do in practice now is give it 2 or 3 days. And this is empiric. I think it's sort of a tension point of what's length of stay in the hospital, what gives the patient a time for the dust to settle. Oftentimes, depending on the infarct-related segment, there may be other assessments that are done. They may be looking at left ventricular function to see if there's a dense anterior akinetic segment and what would be the pharmacotherapeutic intervention. Would they need to be on systemic anticoagulation thereafter? And all these things can influence how people make these decisions. So I think waiting a couple of days is what we tend to do. Whether or not people and patients, interventionalists, patients, clinicians are comfortable to let them go home. If I saw my patient that I showed with that right coronary cleft-like stenosis and, persistent ST depression at the time of the PCI, I would not feel comfortable to let that patient go home. I would have treated that patient in the hospital. If there was a bland, diagonal 70% stenosis that was in the mid vessel, and we're saying, do we need to do it now? It's Friday. Can we let the patient go home? We bring them back. There is, however, a reporting structure whereby if you bring a patient back for a repeat revascularization within 30 days, it counts as a penalty for your institution. And so people will often wait for 30 days as well. And that's just sort of a complex political driver as well. But I think always we focus on, what's the appropriate for our patients and what helps us to make the best decisions for them.
Thank you. We have a question from one of our first-year cardiology fellows, Lee Eschenroder. He says, thank you for a wonderful review of this topic. You made the distinction early in your presentation that non-infarct-related artery lesions are not the lesions that are the subjects of studies like COURAGE or ischemia. Can you talk more about how we know these lesions are different? Otherwise, it seems like there's evidence pointing in opposite directions in the management of the same burden of disease.
Thank you. I think, I almost have to point to the data or the outcomes to say that we suspect that they are different, particularly because in these studies, and especially in ones like the subgroup analysis of Compare Acute in flower MI, the deferred lesions that were FFR negative, but might have been borderline, they weren't like 1.0 when you did the FFR, they were, 0.88 or so. Those are ones in which we would defer the treatment of them. And we find that there's probably something about the pathobiology that causes them to, be vulnerable or to become activated somehow within 4 to 6 months thereafter. And those are patients in whom, we feel that the treatment ultimately is required. In COURAGE and in other studies, certainly FAME and DEFER and others that looked like at FFR use in chronic stable angina, we found that there isn't really that type of penalty for the need for urgent revascularization as commonly when they're deferred based on that cut point. So it's a little bit of, I'm kind of defining it by the outcome, but I think that we recognize that there probably is something to the pathobiology. I think understanding better, maybe at some point we'll be using near infrared spectroscopy to look for, some lipid-rich plaque, or we might be using something to measure the temperature of the plaque. We may be using OCT to look at, vulnerable features of the plaque. And there have been other studies, including the Prospect trial for empiric treatment of lesions that look to have some angiographic narrowing to suspect that they will not someday become vulnerable. So treating, a stenosis to prevent future vulnerability. But I think it's just different in a patient who presents with ACS for the variety of reasons that I articulated.
Thank you. We have a question from Dr. Larry Dean, who says the oculostenotic reflex is definitely an issue in these trials. Thoughts on blinding the patient and the cardiologist to the angiogram of the non-infarct vessel findings?
I think that's a great point. I absolutely think that these, potentially unwarranted subsequent PCIs can be fueled by the, clinician who follows the patient longitudinally. Maybe there could be a way to dissociate the one. I don't know that you can blind the operator who's doing the PCI to whether or not there's another stenosis. I think they inevitably will see it as they perform the angiogram. So I don't know that that's feasible to tell them just don't look. But by the same token, I think that maybe there could be a treating group and there could be a clinical follow-up group, and that group is dissociated from those data and don't know it, and it's not permitted to be shared with the patient. In Orbita, in that particular trial, there was the opportunity for sort of sham blinding. Patients wore headphones, and whether or not angiography and treatment was ultimately performed was what they were blinded to. So I think it's possible, certainly, to blind a patient to the finding, and that might help to kind of shed a little bit more light on this.
Thank you. We're coming to 8:30, so I think this will be our last question. Dr. David Dechek asks, as you so well pointed out, repeat revasc as an endpoint is complex and possibly problematic. Can you distill down to what strategies clearly show mortality benefit or harm?
Yeah, I think that from the studies that permitted repeat revasc, it does confound our ability to state that hard endpoints were met. I think there are enough of these kind of amassing that we have seen in which there also are hard endpoints that are being met by this sort of pacification or treatment of these auxiliary lesions at the time of acute MI presentation that suggest that we should be considering embracing this more broadly in our patients. And I think that has definitely influenced our practice pretty dramatically, and the guidelines reflect that. But in terms of like how to know whether a repeat revasc is like driven by acute ischemia as opposed to patient reports chest pain, and we know there's something that was left untreated, is going to be hard to distill. So I think that does remain one of the really important unanswered questions that we have. And I think comes back to a lot of the questions that have been asked here just now about how do we really know like what really needs to get treated. But I hope that, with our future studies and perhaps a more broad application of the use of physiology and imaging, that we'll have a lot more to share in the years to come. And certainly there's a really exciting pipeline of clinical trials, so that will continue to inform our decision and hopefully help us make decisions at the point of care and beyond for our patients.
Excellent. Thanks so much, Dr. Drachman. And I think we'll wrap up here for our grand rounds. Thanks to all of the audience members, and have a really great weekend and Friday. Take care.
Thank you so much. Thanks for inviting me.